I'm a board certified child, adolescent, and adult psychiatrist, and have helped over 230 PMHNPs gain clinical confidence in their psychiatric diagnosis skills and treatment skills and helping them get over imposter syndrome. So, in this video, I'm going to be covering serotonin syndrome likelihood. How likely is it that a patient is going to get serotonin syndrome? So, this stemmed from a question that I got in our PMHNP community where she asked essentially that she had a patient who was on Zoloft, Flexeril, and BuSpar. And how likely is it to cause serotonin syndrome? That was the question because she was worried about that. So what I explained to her is that there's a tier list of when it comes to things that'll cause serotonin syndrome. And serotonin syndrome has like symptoms like autonomic dysfunction, nausea, vomiting, pupillary dilation, sweating, seizures. And I'm not getting into those symptoms of it here, diagnosing it, but there's a tier list that comes with how likely something is to cause serotonin syndrome. So if I put high tier, I'll separate it into two ones. So high tier, so this includes SSRIs. This also includes drugs like MDMA because these flood the system with serotonin. Like that's their mechanism. SSRIs exist to flood the system. So TCAs are also higher on this list. Now, lower on this list, low tier, this is stuff like BuSpar, Imitrex, a migraine medication, Flexeril. So what does this mean? So this, for example, BuSpar targets a specific serotonin receptor. Imitrex has some serotonergic activity in the blood vessels, but it doesn't really flood the system with serotonin. Same with the Flexeril. It's got some offhand serotonin activity. These ones, they flood the system with serotonin, whereas these, they just slightly increase serotonin. So you see the difference here? And so because of this, for example, in this scenario, the patient would be okay because the Zoloft is the high one and Flexeril and the BuSpar, these are low tier, so that's fine. Obviously, the dose matters, so I'll write that here. Dependent on dosage. So obviously that Zoloft 200 has a greater risk than Zoloft 50. That's pretty obvious. However, now when we compare the low tiers, their dosage range doesn't really matter as much. So I'll still write that like Zoloft 50 is greater than BuSpar 60 plus Imitrex plus Flexeril. So this is a range, it's kind of like a guesstimation. There's no exact data that says that. There's no exact mathematical formula that says that, okay, these three combined is less than Zoloft, or these three combined are more than Zoloft, but then if we get rid of the Imitrex, it's less than Zoloft. There's no like thing like that. It's all kind of a relative gauge. But the point is that it's dependent on the tiers, so the high tier ones, and then it's dependent on the dosage. Obviously the higher dosage of the Zoloft or the MDMA or the TCA, then that's going to cause more of a thing. So what you want to do is avoid combining high tiers. So you want to avoid combining some of the high tier ones. So no Zoloft plus, Effexor plus, let's say, Vibrid. So this is a no-no. Obviously, same thing with the MDMA. So people will ask, like, can I do MDMA, go to a music festival when I'm taking the antidepressants? And so the answer is no, it's not ideal to do that. Of course, patients will make their own decisions. And if the patient is absolutely adamant that they want to do it, then there's various things you can do, such as like decreasing the medication ahead of time. But you want to avoid combining the high tiers. And then Secondly, the only exception is SSRI plus TCA augmentation for OCD. So this is something that's commonly done in clinical practice. And one of the reasons is because TCAs don't just target serotonin receptors, rather they target norepinephrine receptors, and there's some histaminergic activity as well. So because of this, the serotonergic activity is diluted. So this is a common practice that's done for OCD treatment. But other than that, like, you ideally would not be combining multiple SSRIs. But I hope that explains serotonin syndrome and what makes it higher risk versus lower risk. It's important to understand, so that way you can prescribe for your patients safely and clinically and ethically. And so if you have other questions like this as a PMHNP and you want to learn real world psychiatry, prescribing, diagnosis, and treatment from a psychiatrist, best place to do that is our PMHNP coaching community, where we've had over 230 students go through so far and really level up their clinical skills. So definitely check that out, and I will see you in the next video.